Good morning and welcome to the Readmission Refuel Phase 3 webinar. We have just a few instructions we want to review with you before we begin our session this morning. Please do mute your phone lines as you enter the conference space and avoid placing your call on hold. We would really encourage you, if you haven't already located the chat function through our pre-conference time, please do so now. We'll ask that you can do take the opportunity to engage with us through the chat space. Go ahead and type in any questions your team has as you're listening along today, and then we'll be sure to go through those questions and provide answers to you in our Q&A session near the end. A reminder that today's session will be recorded and transcribed. So if you've got team members that couldn't make the live event today, or maybe that have to step out early, we will be recording this session. I'll be sending the Refuel team leads out the links and PowerPoint as soon as they are available, likely Friday or Monday morning. Additionally, this information will be archived in Innovation under the Readmissions Refuel project folder. So before we go any further, I'd like to take a moment to pause real briefly and ask that if you are listening along with other members of your team, would you take a minute and navigate to the chat and just let us know how many people from your team you're listening with today so we can capture our attendance for today's event. Give you just a minute to do that. Thank you. I see some of those coming in. Great. Looks like several teams listening together. Well, I think most of you know our Refuel project team by now, but if you're new to the team and joining us for the first time today, we'd like to extend a special welcome to you. My name is Kate Carpenter, and I'm one of the Quality Improvement Advisors for the Compass HIN and the Refuel project lead. With me today is Dr. Amy Boutwell from Collaborative Health Strategies. She serves as our expert advisor for the Refuel project. And as always, we have a robust session planned for you today. So without delay, I'm going to turn it over to Dr. Boutwell to get us moving with today's agenda. Oh, we can't hear you, Dr. Boutwell.
Oh, Kate, can you hear me now?
Yep, I can hear you now. Go ahead.
Okay, sorry for the glitch there. All right. So going back to the agenda just for a second, I'm going to review for you the results of the Phase 2 survey that you all filled out for the collaborative. There is so much great work going on, and the funny thing is, as I kind of step back, I poured through every single thing you all wrote in this survey, and it was just fantastic. And the funny thing about my impression is I feel like maybe some of you don't feel like you're doing enough, but I want to go through the Phase 2 survey and point out just how much is being done. And for every team that feels like you know, they might not have done enough in one area or another, there's another team on the line who has called that a success for their Phase 2. And so by all means, during this time together, in the chat, and as you work with Kate and the collaborative team over the next phase of work, I really want to highlight how much really good work is going on and how much you really do have to learn from each other, because there is a lot of wisdom and a lot of experience even among us gathered here today. So I'm going to take a few extra minutes to go through what we've harvested from you in terms of what you're doing, what you're thinking, what you're struggling with, and where you're getting some success. So that, and really this is for you to take notes and make notes and say, I want to follow up with that team who's doing, who seems to be doing well on something that we're struggling with still. So then we'll move into the topic for phase 3 of our REFUEL collaborative, which is engaging the emergency department in our readmission reduction work. And then we'll wrap up with some recommendations and next steps. And by all means, please do remember to use the chat. I'll be keeping my eye on it as we go forward. So by way of objectives for today, I've already outlined an implicit objective, which is I hope you'll learn from what's going on among the other teams in the collaborative so that you can be sure to learn from each other as you move into this phase 3 of the collaborative. But in addition to that, by way of new content, I hope you'll really come away from this time understanding why the emergency room is an important setting for you to extend your readmission reduction efforts into. And I want you to ask questions. I know this is new. This might be new territory. This might be a new strategy. And so I want you to feel free to really kick the tires and make sure you understand why we're presenting this to you for your consideration. Number 2 is I'd like to have you be able to describe how to better facilitate what I'll call treat and return decisions from the emergency room. And then finally describe this new tool that's sweeping the readmission practice community nationally called ED Care Alerts, and how teams are using them to reduce readmissions and improve care. And this is a tool that I think is one of the very best things that have come out of readmission reduction work in a long time, quite honestly. Okay, so let's, so I'm gonna recap the 8 refueling stops that we have covered and recommended for your work over the past 2 phases of our collaborative together. And I thought it was just really exciting to see, of course, we proposed the first 4 to you in the first phase and the second 4 to you in the second phase, and to bring them all together and then to reflect on what you are doing. It's really an impressive body of readmission reduction work. And so you've taken a refreshed look at your readmission data. You are committed to using a data-informed approach to identifying your high-risk patients. We've recommended that you take an inventory of existing efforts and resources, including resources into the social services and the community-based services in your community to better support people with social needs. We've encouraged you to engage a hospital-based as well as a cross-continuum team. And then moving into the most recent phase, many of you took up the call to understand the root causes of readmissions, mostly through interviewing patients and their caregivers. Identify readmission risks and post-discharge needs, really taking into consideration the whole person instead of just what somebody needs to follow up on with regard to their specific diagnosis. We encourage you to develop enhanced services to better meet the needs of your high-risk patients. And that's really the types of transitional care services, educational services, follow-up, and definitive linking that we'll talk about here in a second. And then importantly, phase 2 was the time when we were to move into really planning and making specific improvements that are going to be relevant to your hospital and your community and your patients. And many of you have made some great progress in that space. So high-level survey results, about 80% of you have a readmission reduction team, and about 80% of those teams meet monthly. So that's really great. So as I go through this, ask yourself, of course, where do we stand on that? About 65% of teams in the collaborative have tested out the approach of interviewing patients and families to understand why people come back to the hospital, which is just wonderful. And 70% are identifying root causes to inform their readmission work, And 70%, this was an interesting question, but 70% of you have a list of your high-risk patients or your readmitted patients, and you use that list to help you guide and organize your work, which I think is fantastic. Okay, there we go. So many of you reported, what have you learned from conducting these readmission interviews? And I just organized your findings from the survey into what we might call system factors, or things that we do or the healthcare system does, and patient factors. And I really think it is fantastic that what you're seeing are the ways in which the healthcare system is not meeting the needs of our patients. And yes, we do have some patient factors, a lot around engagement and self-management, but what I want you to see here is, as we look for the root causes of readmission, you will find that your team gets ever further away from blaming the patient to looking in a mirror and saying, what are we doing or not doing that we need to address? Because we're the professionals, we're the care, we're the care providers, we're the healthcare system, we're the ones with the, either the resources or the incentive or the education or the insight in knowing what people need in order to not come back. So I really encourage you to look at this list and take some inspiration from the fact that there are many things that we're learning in our readmission interviews that we in the healthcare system can and need to do a little bit better. So these are just examples. These are your examples. I really didn't edit them at all. And I'll just read them out for those of you who are on the phone. In one case, the patient reported that she didn't actually feel well at the time of discharge. And I put that under system factor. Why? Because maybe we rushed her out the door. Maybe we didn't listen to her saying, listen, I feel like I'm coughing more, or I have a fever. And so, first and foremost, we never want to send somebody out the door, especially if they're not feeling well, or if they're feeling worse than they were feeling the day before discharge. So that was very interesting finding. And I will say from my personal readmission interviews that whenever I meet a patient or a family member who feels like the patient was not going in the right direction before discharge, they always bring the patient right back. That's the thing, is we might think length of stay, today's the day of discharge, it's Friday, got to get them out before the weekend, or whatever the case may be. But if we push people out the door, you all know what happens is that they're just going to go right back ahead and bring themselves back. And so I don't call that a patient factor. I call that a system factor, because that's kind of on us, really. So number 2 is the patient didn't understand the education. Now, again, I call that a system factor, because if we hold up a mirror, we say, well, then we've got some work to do, don't we, on our health literacy, on simplifying the message, on customizing the message, on repeating, on using teach back, on engaging another learner who's a care partner. If a patient doesn't understand what we're the simple messages that we are conveying in terms of why you are here, what symptoms to monitor for, who to call, and what medications to take, then we're not doing something well enough. End of life. Patients are being readmitted because they're nearing the end of life. Again, system factor, because we can hold up a mirror and say, well, how are we doing on palliative care screening, on goals of care conversations, on referring appropriately when the time has come to hospice, and to helping patients and their families slow down that cycle of hospitalization at the end of life if that's not really consistent with goals. And so on and so forth. So I think that what you can see here is hopefully the value. These are all insights that you in the collaborative found from interviewing your own patients who are being readmitted. Any chat? Anyone want to chat in anything in terms of your observations about root causes of readmissions or the insights you've been able to get? I'll just kind of touch on a couple others because they're really great and they do relate to a lot of your PDSA cycles right now. Another one was about the patient wasn't educated well about her equipment. And that's a great opportunity because if we have somebody who's using nebulizers or inhalers or insulin pens, walkers, other assisted devices, CPAP machines, there's so much, right? Wound care, self-wound care, and if the patient's not well educated about the equipment and how to use it, well then clearly the patient's not likely to do well in the next 30 days. And so many of you are looking around to the other departments and disciplines within your hospital and saying, oh, maybe we should get respiratory therapy more involved, or the diabetic educator more involved, or the nutritionist more involved, or the pharmacist more involved. And these are perfect examples of why connecting the dots between why did that human being, the patient, really come back, and who could meet that need so that patients like her in the future can have their needs met a little bit better and be just that much less likely to have to return to the hospital. Some folks didn't know when to call the PCP. Some patients didn't have money for meds or transportation, or they didn't have a PCP and they lacked follow-up care. So we know these days that we should be looking for these things when we're assessing patients, when we're creating discharge plans, and it's just not an acceptable transitional care plan if we're sending people with a list of 22 medications out the door and we either haven't asked if they can afford the meds or we've ignored the reality that they cannot afford the meds. There is a lot we can do to simplify and make choices about medications, many medications, not all, to make sure that we're choosing the lowest cost generic equivalents. Or sometimes successful readmission teams have their financial their financial insurance coverage folks help people enroll in Medicare prescription drug plans, or whatever the case may be. So we can't send people out the door these days without asking and confirming that they can afford these medications. In many cases, we need to be, smart about not all the details of every health insurance plan. That's much too much to ask, I know. But we kind of, the docs and the nurses on the floor, we kind of know what the new expensive meds are. And by starting somebody on a new expensive med, then we should ask ourselves, is their insurance plan going to require a prior auth for this when they get to the pharmacy? What's the risk that this patient will not be able to afford this medication when they leave the hospital? So too with transportation and follow-up. It just doesn't make sense with any modern standard to allow, especially a high risk of readmission patient, leave the hospital without knowing what the follow-up plan is. Sometimes that's they've been here for surgery and they need surgical follow-up. Sometimes they've been here because they missed dialysis and they're going to follow up at their dialysis center. It doesn't always have to be a community-based primary care physician, although of course that's what we always pursue. But there is usually some relevant way that we can find patients to get the follow-up that they need, even if it's not a community-based primary care doc. Okay, so lots and lots of insights from your readmission interviews. Let's see, Kate, could you advance to the next slide? Thanks. Now this, you might just want to take back to your readmission team, and I know many of you are meeting as a team right now, but these are direct quotes again from the survey that I just thought were so insightful and really will help you all learn from each other. I learned from these quotes as well. Here are a couple key quotes that I loved. We've been conducting readmission interviews for some time. It's great to get the patient and family patient's perspective versus the healthcare team's perspective. I love this one. Patients are pretty willing to discuss why they came back to the hospital. They're willing to give us the information. We just need to ask. And, that's really consistent with my experience as well. I can't really think of a time when somebody didn't want to discuss. Maybe they couldn't, or maybe they were de minimis with detail because they were limited in some way. But if we ask, people will tell their story. So I love that one. We need to change how we do patient education. When we talk to patients, we really understand immediately what is their level of literacy, what's us, and sequence information, especially about what needs to happen in order. And there's no substitute for talking to the patient to figure out what level they're working on. Another quote was, my greatest lesson learned is that we think other care facilities should know what to do because they are medical professionals, but they can't read between the lines, and they need specific details on what their patients need coming to them or coming back to them. And, this is a great topic for today, and couldn't be more on point. One of the reasons why we're in this readmission situation we're in is that we assume that people will, that the receiving providers, and especially nurses in skilled nursing facilities or home health care, will just know how to pick up and continue on without detailed information. And what I really love about this is it pushes us in the hospital to think 2 or 3 steps ahead. So yes, the patient, we're sending a patient with pneumonia out on, let's say, a new antibiotic for 10 days. But now we need to think, wait a second, they're also on Coumadin. So what is this antibiotic going to do to their INR? And we should write, that the patient should have their INR checked in 3 days. And that the antibiotics are known to affect the anticoagulation. And so in the past, we would just say, well, a nurse or a skilled nursing facility or a PCP would know that. Well, I don't doubt that they might know that. But with the volume of patient care that we're all engaged in, it is our obligation as the sending provider to think 2 steps ahead for the receiving provider and say, here's the situation, patient's coming out, new med of this, check that, follow up on that. And we should do a better job as we send the patient out the door to help that receiving provider know exactly what they need to do, especially in the next couple of days. And so I really relate to that person's quote very well. I love this one. The family has good insight into the problems. So for those of you who have been interviewing the patient, bravo, and I'm really, really appreciative that you've gone that far. Now ask yourself, have we included the family in that discussion? And I'll tell you, you're going to learn a whole new bucket load of information as soon as you get, the wife or the daughter or the son who lives across town, whatever the case may be. As soon as you get the family to start to provide input as well, you're going to really flesh out the picture. So let me just see. Another quote was, I like this one at the bottom here. We need a better admission interview with patients to determine their additional needs prior to that first discharge. So I'm really glad that whomever said this made this point. The readmission interview, i.e. interviewing the readmitted patients to look backward and ask ourselves what were the circumstances that led to the readmission, that's really to get us all in line with the focused root cause analysis exercise and skill set. But the person who wrote this quote in our collaborative is absolutely spot on. now that we start to know that root causes include a lack of full understanding of what to do, a lack of follow-up, difficulty affording meds or transportation, feeling like they were sick when they left, having more needs than we recognized, etc. Now that you start to amass your root causes based on your readmission interviews, you absolutely bring that insight to the top of your process, which is, what do we look for the next patient the first time they're admitted? So tomorrow you're going to have Mr. Jones. He's going to come to you for the first time with pneumonia. And now, because you know about what readmission risk factors are, now you're going to ask yourself, and you're going to ask Mr. Jones during the hospitalization, do you have someone to take care of you and drive you around? Are you worried about affording medications? Do you have a PCP? And what do you understand, Mr. Jones, about why you're here? And make sure that he has all of those things in place. That's part of your readmission reduction work for Mr. Jones, even though he has not yet been readmitted. So I really appreciate the person who made the point. We bring our insight now to improve care and our methods for improving the discharge process and reducing readmissions across the board. So thanks, Kate. Next is we've been moving to action in this stage, and this is the breakdown of where you are as a cohort. We've got a lot of people actively planning. We've got a great amount of people who are in do, study, and act. And so just congratulations to you who have moved into work. And of course, much of your move into work has started with patient interviews. And here are some of the projects that you all are working on. Sepsis readmissions, we've created new sepsis discharge instructions. We've asked our respiratory therapists to do more education for COPD patients, always a great idea. We have looked at where our patients are going to other hospitals after we send them off to a skilled nursing facility. We've made appointments for our high-risk patients. We are rounding now, I love this, with coaches, the health coaches, the social workers, PT, OT, nutrition, and pharmacists. So they're bringing together that interdisciplinary team to round on the high-risk patients and put our heads together. We're improving our assessment of social needs. We're looking at the ER. We're implementing this new tool, I guess, out there called Health Loop for engagement and education. Some teams have established a COPD team. I love this one. Unit clerks are going to identify the readmissions on a daily basis. It's a great way of using your existing resources. You're conducting readmission interviews. You're including home care agency in your readmission huddles. I love that. You're expanding the cross-continuum team, and you're improving the post-discharge call process. So lots and lots of good work going on. Next slide. In addition, we asked if you have planned an intervention, what phase are you in? And so if you have planned actually something to do, have you started it, have you implemented it, or not yet? And here are the specific actions that you as a collaborative have taken. You've, of course, done patient-family interviews. You've engaged diabetes educators to work more deliberately with your inpatients on using, especially I think it was insulin pens while they're here. You've asked your pharmacist to review meds for your high-risk target pop. You've asked your respiratory therapist to do more education at the bedside. You are mobilizing 30-day medication packs. You are engaging in multidisciplinary rounding for your high-risk Medicare or high-LACE patients. You're changing the care transition referral forms. You're using Health Loop. You're providing 2 transitional visits for your high-risk patients. I love that. You're increasing follow-up visits with your primary care. You're conducting follow-up calls and appointments for everyone over age 66. Very robust approach. And we are increasing specific we are making sure that there's a specific contact person, a health coach or a care manager who follows the high-risk patient for 30 days. So I'll tell you, look at what here's the thing. Each of your teams are doing maybe 1 or 2 of these things. or maybe you're thinking about them. But look at what this list represents. This list represents almost all of the best practices out there, right? I mean, this list is a very robust, multifaceted list. And what I really commend for your consideration is this is almost all of this list is using resources that you probably have at your disposal as well. Not every single thing on this list, but most of you probably have access to most of these options here. So really look to each other to see what each other is doing and draw inspiration and specific ideas from that. Next slide. Okay, I think this is one of the last slides in terms of where you are and what you've been doing. And again, I just want to highlight some of the successes and challenges that you have said that you've had. Number one is some hospitals are really happy that we see departments coming together. There's a sense of teamwork. You've established a team where you had none before. You've actually picked a time to meet, and one team even identified that they're meeting Monday, Wednesday, Friday, but some other teams at least were just happy they're meeting at all, and so those are all victories. You've identified a target population. You've developed a readmission huddle tool, which would include the patient interview. You're actually using the information from the interview process to inform your work. You're clinically assessing risk, not just using a score, but you're saying, and if we also identify somebody with a clear readmission risk factor, we bring that to multidisciplinary rounds. I love that. You added to your team, specifically in this case, respiratory therapy. You've increased the number of transition visits for high-risk patients. Great idea. You're working off that root cause that says people need more contact. They need the more timely follow-up. Everybody's on board with a 3-day follow-up, so that's great at your hospital. We've mobilized more services for patients. We've given our partners, our cross-continuum partners, I think in this case, I'm inferring it might have been a home care agency, the list of high-risk patients. The great idea there being, if we know they're high risk, then we should let our receiving partners know that the patient is high risk as well. That is a great idea. And then one of you, I think, has engaged the ED. Some challenges. And many of these challenges were universal from last time as well, and we definitely recognize that, which is a reality of the world we live in. But time, no team, competing priorities. Some teams are having a tough time getting interviews done. And then I just offer, and other teams have found success in getting those interviews done. One team was having trouble getting their colleagues to understand the purpose of a care transitions team. And then here are just a couple things I wanted to, I thought were quick hits that I might give a little perspective or advisement on for those of you who mentioned these things. So one team mentioned that they had OB patients showing up as readmissions. And I just wanted to mention, we said this at the top of the collaborative back in webinar number 1, but the way Medicare looks at readmissions is the way most everybody looks at readmissions, which is it's adult non-OB. So right then and there, OB is not part of this view and perspective. Different population, different reasons they're coming to the hospital, and hopefully all OB patients end with a happy delivery. So great point, and I just wanted to really clarify that for the group that non-OB, we're really not looking at the OB. Although I see that that Kate is clarifying what we have in the data, and so from a clinical operational standpoint, I would say to you, we're not often looking at OB as a readmission issue. Although every once in a while you find a troubled pregnant woman who really does need more support, and it's not about her pregnancy so much as it is about the other things in her life. And of course, we all know that person would want to get connected to the services and supports she needs in order to have her needs and issues addressed successfully. Okay, so the next is one team, or one or two teams actually, reported that they had a delay in approval for like new education forms or for changing something in the EMR. And so I just wanted to make a quick point about this. Forms committees can really bog you down. I have seen it happen before. So here's the way I like to PDSA approach the improvement of patient education materials. And it really is to use the PDSA approach instead of redrafting a form and putting it in form committee and waiting a quarter or two for it to get approved. If what you know is that your sepsis, for example, your sepsis readmission or your sepsis discharge instructions are not clear enough, they're not simple enough, maybe they don't address kind of those core questions that we all know from the HCAPS transitional care questions. Why am I here? What red flags to look for? And who do I call if I have questions, right? We all know that we need to simplify our educational material to answer those questions. So what I recommend is that you test it one sepsis patient one day. And then you do all of a nurse's, patients the next day. Then and then for a week you test it on the floor. And you test it by truly testing it, by asking the nurse to use, let's just say, your simplified teaching points, to adopt the teach back method. And as he or she uses your simplified and improved patient education teaching points, that nurse will have feedback for you. Like, this wasn't clear, that didn't really work for the patient. And then you modify it. Oh, okay, we were saying, observe, classic is lower the sodium in your diet. And nobody knows what sodium is, but they know what salt is, right? So you want to test it, one nurse, one floor, 1 week, the next floor, another week, and get feedback. And in that case, in that way, you continue to tweak, you continue to refine, you continue to improve, and then you take it to the forms committee, recognizing that it will take some amount of time before the form will be approved. But at least you know that you're presenting a much better, essentially field-tested version of whatever form you're seeking approval. So that's just one little lesson from the field on that. Some people said patient engagement and physician engagement are challenges. And I just wanted to quickly touch on those. Number one is, whenever I hear patient engagement, and there was a longer version of this feedback, the patient really doesn't want to change. They really don't want to know anything about managing their disease. So whenever I hear that, I ask myself, is there a mirror that we need to hold up in front of us? And are we sure that we're using the right approach, that we're using motivational interviewing, that we are approaching the patient on their level? And really, in motivational interviewing, it's not about teaching the patient about COPD, right? As many of you know who've been trained in motivational interviewing, it's about asking the patient, are they cool with coming to the hospital every couple of weeks? Is this okay with them, or would they rather spend their time in a different way? And connecting to a preference and a goal that the patient has, which might be, I want to be home with my cats, right? Okay, great. Let's talk about how we can achieve that. And in the course of doing so, you're helping the patient achieve their goal while you're executing on your professional objective, which is to teach the patient about COPD management. So there's a lot we still have to do, all of us, myself included. We all can do better with understanding how to better relate and engage to patients so that we can deliver the information that they need in order to achieve their goals. So physician engagement is a really interesting one, and something that's been a real surprise for me in my career. There is a lot that each and every one of you can do. and that I do even as a doctor that does not involve doctoring, right? And almost by definition, transitional care is not really medical decision making. And so I find that there's a lot of power in saying, what can we do? And if you've got physician allies and champions and docs that are on board, wonderful. But if you don't, I really wouldn't sweat it. You guys are the ones who assess for readmission risks. You link to services in the community. You make follow-up appointments. You make post-discharge calls. You ensure that people have their 30-day medication supply before they leave. There's so much we can do that I would recommend not letting physician engagement or the perception that your docs don't care about readmission reduction, that there's so much you can do that you just move ahead with all those things that you can do. Lack of buy-in regarding LACE. Quite frankly, I have a lack of buy-in regarding LACE. But the honest answer is, if you have a lack of buy-in regarding LACE, in particular, that's a readmission risk tool, then you might, instead of saying we want everybody to embrace LACE, you might ask the question, well, why? Why don't they embrace LACE? Is it because they don't believe we need to identify patients at risk of readmission? That's one problem. Or is it because they don't buy into the actual LACE algorithm and they don't actually think that LACE is a good enough tool to use? That's where you would find me if you asked me the question. And so, again, really kind of deconstructing your challenge and saying, what kind of challenge do we have? Is it that nobody wants to identify a high-risk patient, or that they have ideas about who's high risk that conflict with the LACE score? And then finally, almost all of you reported in one way, shape, or form that some of your work on some level, because you're community hospitals, critical access, most of you are critical access hospitals, most of you reported various challenges because there were low numbers of readmissions. So I wanted to dig into this because in our collaborative, we have very small, we have medium, and we have a couple of larger hospitals. So when we talk about segmenting, meaning know your high-risk groups and identifying one target population to focus on, I was not clear. I realized I was not clear because if you are a critical access hospital and you only have 1, 2, 3, or 4 readmissions at all in a given month, then your target population is everybody. It's all readmissions. And some of you said, well, we wanted to focus on sepsis readmissions, but we didn't have any sepsis readmissions this month. Then that says to me, we have such low discharge volume that what we really need to do is look at every patient and ask ourselves, is this patient at high risk of readmission? What can we do to ensure a safe, high quality discharge for this patient? And what you're really doing is not targeting certain diseases, but rather saying, we have 5 readmissions this month and our goal is to have 4, right? That's 20% lower. We had 3 readmissions this month and our goal is to have 2. That's 33% lower. And so in that case, disease-specific targeting or even LACE-specific targeting very well may not make sense for critical access hospitals. You might want to take an approach that says we're low volume, which means we can improve the discharge for everyone, which means we are going to try to reduce any readmission, not just a specific type of readmission. So that's something that we might have not been clear about, or I know I was not clear about in my advice in webinar number 1. And I'd really encourage you guys to look at your absolute number of readmissions. And if you are in that category where you only have a literally small handful, 1, 2, 3, 4, 5, less than 10 readmissions per month, then you probably should not segment. You should probably look for readmission risks, make sure people have follow-up phone calls, transitional care if you think they need it, RT education, diabetes education, pharmacy education, if you think they need it, med delivery, if you think they need it, and go from X number of readmissions to Y number of readmissions without disease-specific targeting. Okay, so let's move into our topic for the day. The ED, and I see your questions coming in, and I will definitely, you should answer each other's questions, and then I'll definitely get to questions, or we'll follow up in an email after the webinar. So the ED is an important setting for readmission reduction. So why do I say that? Oh, next slide. We've been taught that the best way to reduce readmissions was to improve the transition out of the hospital. All of us were taught that. We need to do better discharge planning, and we need to do better follow-up, and we need to do better transitional care. And all of that's true. However, as the past 10 years of readmission reduction work has progressed and evolved, I have noticed that many innovative, successful programs do not stop with transitional care and post-hospital follow-up. They absolutely include, as a core strategy of their work, the emergency room. And so I'm listing out, whether it's a bundled care program or ACO programs, or the innovative work going on in the state of Maryland, or other demonstration projects. More and more work includes the emergency room, and so that's why we're bringing this concept to you here in phase 3. This is not experimental, and it is not unproven. This is a set of strategies that have proven to be very successful to some of the largest and most ambitious readmission reduction programs in the country. Next slide. So here's just the thought, kind of the thought model here. If you look down at the lowest arrow, the smallest arrow, you'll see the definition of a readmission. The definition of a readmission is discharged from the inpatient setting and readmitted to the inpatient setting. And that's what a readmission is. That's how Medicare measures it, and most everybody. The middle arrow is discharged from the inpatient setting and readmitted either to OBS or inpatient, but we don't usually see the OBS part of it, right? That doesn't count as a readmission. And then the largest arrow is what I'm going to call the ED revisit, discharged from the inpatient setting and returned back to the emergency room. There are literally twice as many people who are discharged from our hospital who return to the emergency room than we see reflected in the readmission measure. Let me show you another graph. Next slide. So we did this research, and for your emergency room colleagues who might want the data, I've cited two papers that I've been a part of on this topic. The concept here is who's discharged from the inpatient setting and who comes back to the emergency room, whether or not they get readmitted. And so the data from Massachusetts, you can see we looked at all discharges, and then we asked the simple question of all inpatient discharges. This was all adult inpatient, all payer, all diagnoses, all adult discharges from our hospitals in Massachusetts. How many came back to the emergency room within 30 days? Answer, 26%. Most of you in Iowa are gasping right now because you guys are nowhere near that bad. We've got a real issue here in Massachusetts. So 26% of our patients discharged from inpatient setting are back in our emergency room within 30 days. And then we asked the question, if you came back to the emergency room, were you readmitted to the inpatient status, or were you discharged from the ED back to wherever you came from? 50-50 right now. And so, we walk around Massachusetts saying our readmission rate is 13%, right? because of all patients discharged, 26% come back to the emergency room, but only half of them get readmitted. So we only see that half, right? Quote, upstairs, we only see half of the patients who actually came back to the emergency room. So this, and Joanne, just for clarification, from tertiary centers then to our own facilities, right? Okay, so so the opportunity here, we've got two opportunities. Number one is the top box. Number one is for all of our patients who are being discharged, we don't want them to go back to the emergency room if it's not needed. And so we have an opportunity to push down the frequency with which our discharged patients go back to any emergency room, whether it's your emergency room or someone else's emergency room, doesn't matter. We're talking about humans and patients and what they experience. And that is probably through good transitional care, right? That's what you're already working on, is top box number one. We're giving better meds, we're giving better education, we're making follow-up appointments, we're telling them who to call, and advising them, what to look for and to go see their PCP and to make those appointments. And all of those things are going to push down and influence the top box, reducing the likelihood that our patient is going to come back to the ED at all. But then the lower box is the new opportunity I want to bring to your consideration, is just because they come to our emergency room does not mean that they need to be readmitted. First of all, you say, well, right now, current state is that, and again, this is based in Massachusetts, but this is all big hospitals, small hospitals, teaching hospitals, non-teaching hospitals. It's everyone thrown in the mix. So right now, if a patient bounces back to the emergency room, chances are 50-50 that they're going to be readmitted. Well, if chances are already 50-50, by definition, that means you can have a discussion with your emergency room providers to say, do you agree that some people who come back soon after discharge are sick and need to be readmitted? Answer, yes. And do you agree that some people are not sick and they don't need to be readmitted? Answer, yes, because that's the current state of affairs. And so I know that some of you have been concerned about the work in the emergency room because you might perceive that people who come to the emergency room have an emergency and they're actually sick. But what I'm showing you this data for is to show you in plain numbers that as many people are treated and discharged as readmitted right now from the hospital. So what we can do is we can improve upon that to say, can we get a little bit better? Can we readmit 40% and discharge 60%? That would be improvement. So let's talk about how we might do that. Next slide. This slide is just great reminder of the patients that you guys are already thinking of. So what we see in the left-hand side of the box is the number of patients who were discharged from a hospital who had at least one emergency room visit within 30 days. That's on the left-hand box. The right-hand box is the total number of emergency room visits those patients had. And what the exploded column is showing you and reminding us is that some people don't just come back once, they come back a whole heck of a lot. And that group of patients is really, kind of starts to move into that high utilizer category where they're really coming back over and over and over again, using the emergency room probably unnecessarily and probably for primary care or for other reasons. And so this was just a reminder that we have those high utilizers in this group as well. Okay, next slide. So if you think about, now that you know the data, and we know that readmissions are not just about who was discharged from inpatient and readmitted to inpatient, but now we're thinking who was discharged from inpatient and came back to the emergency room. Now I want you to really quickly reconnect with the root causes of why your patients returned. And ask yourself, if they said, if they didn't know to call their PCP, if they weren't able to afford medications, if they, what were some of your other root causes? If they couldn't get transportation to a follow-up appointment and they ended up back in the emergency room, do you think they really needed to be readmitted? How often are they returning because they're actually sick and need 24-hour acute care at the hospital setting, right? How many of your patients actually need acute care when they come back? So here's a study asking that question. Again, I bring it back to you. I shared it with you in webinar 1. I bring it back to you now because, again, I know some of you are wondering, how are we going to get our emergency room colleagues interested in this? So this is an emergency medicine publication and conducted by emergency medicine doctors using this technique, the interview technique. And you'll remember from webinar 1, they interviewed 60 people who were ED bounce backs. They found that the patients were younger than expected. They found the patients actually did have a PCP. They found that the patients who were bouncing back just simply liked the emergency room. More tests, quicker care, more likely to get their symptoms treated right away. And when the investigators did their analysis of why do people come back to the emergency room, they concluded that people come back when they have fear or uncertainty about their...
All it is statistics, like...
Oops. Oh, measure...
preventing
can you mute
ER.
yourself? Kate, can you help?
Minimize it, maybe. Okay.
Okay, cool. Kate, you can hear me, right?
I can.
Okay. So they also found, they concluded that patients needed more reassurance during and after their episodes of care, and that they needed more access to advice. Now, these 3 bullet points do not sound like an acute medical emergency to me, right? And so this is where the power of connecting the dots between root cause analysis and bringing your readmission work into the emergency room comes, is because people are coming back because they're seeking reassurance, they're seeking advice, and they had a question that they needed answered. They felt like they needed to come back. I don't doubt that. They felt like they needed to come back to the emergency room, but that does not mean that they need to be readmitted. Next slide. So what can we do about it? Step number 1, recommendation number 1, is we want to increase the frequency of evaluating, treating, and then releasing patients from the emergency room if they're returning to us within 30 days. So we want to change the balance of that little graphic that I showed you from 50-50 to 60-40, 70-30, whatever is safe and appropriate for your patient population. If the patient is not acutely ill, then they should not come in just in case. That's the old way of thinking. And what we in readmission work are doing is moving into the new way, which is high value care, not just in case fee-for-service medicine. Next slide. So here's a great story. In Massachusetts, there was a statewide educational rollout of Interact. And you guys have read about Interact in your readmission refuel guide. If you don't know Interact, go look it up in your refuel guide. It's an acronym that stands for Interventions to Reduce Acute Care Transfers. And it's a quality improvement tool and set of tools focused on the skilled nursing facilities so that they can treat, respond, and manage patients more often, more frequently in their own settings instead of needing to send their patients back to the emergency room. So in Massachusetts, we were really lucky. We got this statewide grant, and each and every single skilled nursing facility was personally trained in Interact, right? Interventions to reduce acute care transfers. And this is what the leader of that educational rollout said at the end of the program. The biggest barrier was engaging the emergency rooms. We sent them more focused, standardized information. We gave them contact information to call us. We let them know what our facility can do and indicated we would be willing to take the patient back. It turns out the packets we sent ended up in the recycling bin and were never really looked at. So this is a great example of our collaboration with senders. When we are discharging a patient, we're the sender, and the skilled nursing facility or the home care agency or the PCP, they're the receiver. You're already doing, and you're telling us in the survey that you're already putting together these cross-continuum teams, and you're working on those better handoff communications and warm handoffs and collaborations and huddles. But what's going to really frustrate the experience is when a patient ends up back in the emergency room and it all goes poof. We hit the reset button. It's Groundhog Day. We start all over again as if you hadn't put all of this effort in. And what happens right now, if we're not doing anything in the emergency room, is just that. It seems like we hit the reset button and all the work you did goes out the window and we start back at square one. So next slide. So having heard this frustration, a chief of emergency medicine here at a local hospital said, okay, that's a very compelling concern that you have. I'm going to look into it with my group. And what he did was he just, in a staff meeting, he said, hey guys, I've noticed that we have a pattern. It looks like basically all the patients who are coming to us from a SNF get admitted. Can you tell me what your thinking is there? What's your experience? What do you see? And he elicited his own 5 whys, if you will, from his staff. And these were docs and they were PAs alike. And what the providers in did was all those kind of old operating myths and assumptions that we have about, other people's care settings, right? And they were all myths and assumptions. Oh, the patients in that facility, they're only seen once a month. They don't have really good medical follow-up. Oh, that nursing facility, they can't do IVs, so I couldn't send them back for IV, ceftriaxone, et cetera. Or there was feedback about, well, if the SNF sends them here, then clearly they're telling us that they can't take care of the patient. And so we have to take them. Aren't we obligated to keep them? So there were some myths about what the other facility could do. And there was also some myths around the signal that the transfer implies that, that we have to admit the patient, we can't send them back. So he, as I showed you, he asked his docs and clinicians why. He got some myths and assumptions and root causes out on the table. And then he did 2 things. He simply educated them. He said, well, let's see if we could do a better job to send people back if it's safe and appropriate. And what I want you to know is that we have these sheets up on the workstations that if you're ever wondering, can the SNF do next day labs or IVs or whatever the case may be, just look at the SNF capability list and it will be there. And we've got it filled out for the 5 SNFs in our area so that you know what they can do, because you know what? They can actually do a lot more than we think they can do. Okay, so it's simple education. And then he, oops, what was that? And then he basically said, if you have a patient from a SNF who comes, why don't you just call the SNF and see if they'll take them back, again, per your discretion, if you think it's safe and appropriate. And so next slide, this is the results of that simple education and simple ask. This was a 9-month little effort that he led. And what you're looking at is month in, month out, how many patients came to the emergency room from the SNF. Oops, somebody's off mute again, who were returned back to the SNF. And many of us know this isn't specifically a readmission measure, but it's a pretty good approximation of a readmission measure. And so they just worked a process over 9 months, and you can see the very clear increase in the number of safe, effective treat and returns that went back from the ED back to the SNF. So this is a great improvement that all of you guys can do. Next slide. So I mentioned some tools that you maybe some of you might be familiar with and some of you may not be familiar with. These tools are referenced in your readmission refuel guide. This is the SNF nursing home to hospital transfer form. This is just an example. Now, I happen to work at a hospital where all of the SNFs send this form. It's really helpful. I wouldn't go down swinging and dying about trying to make everybody use one standard form. But what I really like about the nursing home to hospital transfer form is three things. Number one is I get the most recent set of vitals from the nursing home, not from the emergency room. By the time they hit me in the emergency room, they've probably already had oxygen put on them and a half a liter of fluid bolused, right? So it's a different situation. So I want to know what was going on when that nurse decided to send that patient in. Were they really hypoxic, hypotensive, febrile, tachypnic? What was the real situation in the nursing home? And then I also want to know, in his or her words, why they sent the patient in. And that's here in the middle part of the form. If you take a close look, it's a brief written reason for transfer. That tells me a lot. Was it diarrhea? Was it altered mental status? Was it bad labs? That really tells me a lot. And then finally, the third thing I really like about this form is it gives me a name and a phone number. And I do call that person back. And I do say, hey, this is Dr. Boutwell from the hospital. I'm admitting Mrs. Smith. Can you tell me a little bit? She looks pretty good. Can you tell me a little bit about what you were worried about? We have a brief discussion, and I'm then able to say, so it looks like it was just a UTI. I feel comfortable sending her back. Can you take her back? Right? That's kind of and I'll be the first one to say this is not how I always practice medicine. So I'm not patting myself on the back. I'm just saying that is what good clinical care should be, isn't it? Where we actually talk to each other and say, this is what I see. What did you see? This is what I think. What do you think? And then if it's safe and appropriate, let's send them back. We do not have to admit every UTI from the nursing facility, right? Okay. The other form that you see here is the nursing home capabilities list. That's what Dr. Spardella, in the example that I shared with you, that's what he posted at the workstation in the emergency room for the 5 SNFs. You probably have 1, 2, 3 SNFs in your immediate area. And so it's not a big job. You literally send this out to your 1, 2, or 3 SNFs. You ask them to fill it out. It takes them about 4.5 minutes, if not less. And then you bring it back and you post it somewhere where your clinicians can see it. And you tell them, hey, more than we think we can. So if you get a patient from a SNF, check the list and see if you can send them back. Okay, next slide. The next practice that I'd like to bring to your attention is what I'm going to simply call reach in and transition out. And remember, we're talking about the emergency room. So in long form, this is the team that knows that patient is notified in real time that your patient is in the emergency room. So the expectation or the opportunity is, can you reach in either by phone or physically if you're on campus, can you reach into the emergency room, let the ED providers know, oh, this is one of our high-risk readmission patients. They're in the transitional care program. If you don't think they're that sick, doc, I can certainly facilitate follow-up and discharge to home if you think that's fine. And so what we really want to do is we want to bring into the emergency room the knowledge that you, the transitional care team, exists, and that you, the transitional care team, can be counted on to be part of a safe discharge with good follow-up from the emergency room. Because what the emergency room doctor really doesn't want is uncertainty. So next slide. So what I really learned this practice from the Mass General High Cost Beneficiary Demonstration Project, that's a mouthful, but I share it with you because many years ago now, about a decade, 8 or 10 years ago now, before the ACO program existed, CMS did a demonstration program with Mass General Hospital. And Mass General took on total risk for the 2,500 highest cost, highest utilizers at Mass General Hospital. So these were not easy patients. And the active arm, they approached this challenge to reduce cost and reduce utilization in a very savvy way. They said to themselves, look at these 2,500 people. They come to the hospital and the emergency room a lot. We are probably not going to hit our goals this year if we try to re-educate and retrain all of these 2,500 people on how to access the ambulatory care system. I think that is brilliant insight. They said, but when they come to the emergency room, we can do something different. And that's what they did. I won't read this to you, but I encourage you to read it with your teams. What they did was they flagged their high-risk patients in the computer. Whenever a patient hit the emergency room, the flag went off. The care team, i.e. the PCP and the practice-based care manager, was notified. The PCP or the practice-based care manager would then respond, again, either by phone or in person, to the emergency room, and a simple call-in. Hi, this is Dr. Boutwell. I see Joe Schmo is in the emergency room. He's one of my high-risk patients. What's the scoop? And the ED doc says, oh, he comes in with some, recurrent chest pain, but the EKG is fine and the labs are normal. And I say, well, look, he just had a stress test last month. He has GERD. I think it's probably non-cardiac chest pain. If you feel comfortable letting him go, I'll let you know that I can follow up with him or have my nurse care manager follow up with him tomorrow just to make sure everything's okay. Again, this is the care that we would all want to have ourselves. And the outcome of that discussion is ED doc says, okay, fine, I feel comfortable. We have a safe discharge plan. And so that was the way that Mass General reduced utilization, improved care, and it was because of this program that the ACO program started. Next slide. So a couple quick examples from around the country outside of this Mass General example. One strategy is to co-locate staff in the emergency room. Here's an example from a relatively rural county in Maryland. The health department had a grant from SAMHSA or somewhere to train up peer navigators for behavioral health patients in the county. Well, these peer navigators were not very busy. They were trying to find patients in, group therapy and primary care, and they weren't really finding patients. Well, it turns out that the hospital was trying to figure out who could meet the behavioral health and follow-up needs of their high-risk patients at readmission. And one good fortune led to another, and the hospital readmission champion met the Department of Health, and they figured out that the Department of Health has the resources that the hospital was looking for. And so through a rather informal, somewhat formalized partnership, the emergency room credentialed the behavioral health peer navigators to be co-located in the emergency room to look for patients with behavioral health needs who could benefit from navigation support. So no money out of the pocket of the hospital. The resource that had already been developed in the county that was being underutilized was better utilized, and they had a 30% reduction in high utilizing behavioral health patients, which is who they were targeting. Similar, I won't walk through the detail in the interest of time, but similar success story, emergency room in Baltimore, Maryland, was also doing their root cause analysis interviews, realizing that patients aren't really coming to some patients aren't really coming to the emergency room because they have true emergencies, and that the needs of patients who are coming without an emergency, of course, were not well met in the emergency room by definition, right? We are not well suited to deal with social, logistical, transitional care needs in the emergency room. And so they recognized that they had a lot of people who were in their emergency room. The needs of those people were not being well met. And again, good fortune, they reached out and they were looking in the community for who provides this kind of social support. And they found that there was a community-based organization that had navigators, and they partnered with that community navigator, that community agency, to staff 3 care coordinators in the emergency room as contracted staff. And whenever a high-risk patient was identified, they met with that navigator right then and there in the emergency room. They had a home visit within a week. They were followed for 90 days. These navigators linked patients to medical homes, educated patients on when to call their PCP, did behavioral retraining, and this program realized an 80% reduction in ED utilization for this high-risk group. So this is the way that we can see that situating our readmission reduction work in the ED can get some really, really significant results. Next slide. So the last topic I want to talk to you about in the overall theme of using the emergency room to enhance your readmission reduction work is a very practical tool. We call it the ED Care Alert. And it's really having your readmission team feed forward what you've already learned about your high-risk patient from the inpatient status. You want to feed that information forward to the next provider in the emergency room who does not know their risk score, who does not know their home environment, who does not know they can't afford their meds or they've been connected to the readmission transitions of care team, etc. So what is an ED Care Alert? Next slide. The ED Care Alert, as defined by an emergency medicine leader in Maryland, is a high-value, need-to-know information about a patient to support better decision-making at the point of care. So all of those words are very key. High-value, need-to-know information. This is not the life history. This is not the entire medical record. This is what does that next provider need to know about this high-risk patient in order to improve care in the emergency room. It needs to be instantly accessible, brief. It should be guidance from a clinician, not necessarily a doctor, but a clinician, any and all of you on your readmission team who knows the patient. It should convey what their baseline status is so that, if they come in confused, but they have dementia, are they really confused or are they just forgetful? And it should identify the care team that is ready and able to be contacted for the patient. And it's intended to inform the decision to admit. Now, you might say, well, that's a very nice Christmas list, but gee, who the heck can ever meet that high bar? And I'll tell you, this has gone statewide in Maryland, New York, Massachusetts, Washington State. This practice change is really, really coming. It's really spreading. Emergency room doctors like it once they understand it. And because we are focused on serving them, and we are focused at pushing need-to-know, high-value, actionable information to their fingertips at the point of care. And once this practice change takes hold, it really makes a difference for them, which of course is part of the reason why it's well accepted. Next slide. So ED care plan, why do we call it this? It's a kind of a bulky term. Well, what we're trying to do is separate the ED care plan and the specific type of information, the specific use of an ED care plan from all the other types of care plans that are emerging in population health. So you've got the longitudinal care plan, you've got the transitional care plan, and this is an ED care plan. And my key message on this slide is the word care plan itself is nowhere near descriptive enough for what the job is. It's like a note. Well, is it a social work note? Is it a PCP note? Is it an H&P? Note is not good enough. Care plan is not good enough. So that's why I just wanted to show to you this taxonomy that there can be different care plans and different care plan types, and don't let that, be a barrier to understanding what we're talking about here. All right, next slide. Here's an example. I think this is one of the most amazing examples. It's from this Dr. Pat Zapp, this emergency medicine leader in Maryland. And I think that it will show you exactly why a care plan is different from other, an ED care alert is different from other care plans. It's different from a discharge summary. It's different from a PCP note. Let me just read it out here for you. Mr. F is a gentleman who commonly dials 911 on weekends and holidays. Right, so number one, that's the definition of not an emergency. Noting shortness of breath. He does have COPD, and his baseline everyday physical exam is notable for wheezes and rhonchi, meaning, dear doctor who doesn't know Mr. F, every time you listen to his chest, you're going to hear stuff. His chest x-ray will show a left lower lobe infiltrate that has been stable for 15 years, meaning just because you see smush on the chest x-ray does not mean it's pneumonia. Please call his PCP, Dr. Pat Zapp, happens to be her, on her cell phone if you are contemplating invasive testing or admission. So please call me. I'm the doc or I'm the person on the care team who knows this patient's baseline. Please call before you admit the patient. Please note the patient can be and often is seen daily in her office, which is located in his apartment building. I can't make this up. Please note he has low literacy skills and will not be able to comprehend written discharge or medication instructions. So this is even long for a care alert, but what I love about it is it shows you the type of need to know information. So if Mr. F comes to my emergency room on Thanksgiving night, and he says he's short of breath, and I listen to him and he's wheezy, and I look at his chest x-ray and it has a left lower lobe infiltrate. What I now know is don't admit him for a COPD flare/pneumonia again. Why don't you call Dr. C and get her opinion, because maybe Dr. C just saw him yesterday, right? This is really helpful information. Next slide. So how do you pull it together? Here's a example process flow that really allows teams, and I've used this with hundreds of teams across Massachusetts, Maryland, New York, Virginia, and Georgia. Hopefully you guys as well. There's a simple process flow. Number one is we want to be able to identify the 30-day return patient in real time when they hit the emergency room. Some of you might have your registration clerk do this. This is a administrative secretarial clerk level information pull, or it's already baked into your EMR, which is very common these days. So number one is we want to identify the patient who's coming back within 30 days. Number two is then we want to notify. So identifying is not enough. We need to identify and then notify a human being. So the ED docs or providers would see that visual cue on the tracker board. Maybe the name maybe there's an icon that flashes or the name turns a different color. But the important thing is, who do you want to have respond to that patient? Remember my reach in, transition out paradigm? So can your readmission team, again, during regular working hours when they're here, start with that, but can the readmission prevention team or the community care team or the PCP care manager be notified so they can then respond, step 3. So we need somebody to be notified that their high risk of readmission patient has, yes, returned to the emergency room. And the third step in the process is respond. So respond can either be an ED care alert flashes, like the Mr. F commonly calls 911 on weekends and informs that provider about the chronic care-seeking pattern and the available support options to that patient. So that would not involve a human being. Or number 2, the accountable team, meaning the readmission team, the PCP care manager, the readmission prevention team responds virtually or in person to facilitate discharge. That's my Mass General and Carroll County and Baltimore example. The final step in the process is manage. Then we want to make the decision. We want to utilize the care alert to promote safe, consistent care, which often means reconnecting the patient to the services and supports you've already put in place for them because you've already done it in your good discharge planning. And then we want to be able to offer follow-up support and to make sure that the patient is safe if they're discharged from the emergency room. Next slide. So this quote is from the director of the emergency room in a high utilizer program that I worked in New York. And this is what he said. In previous times, the path would have been to simply admit the patient and we'll sort it out 5 days later. We're becoming more accustomed to having resources in the emergency room to help us discharge the patients from the emergency department. That is a culture change. And that is what we're talking about, but that's why we wanted to bring this content to you during phase 3 of the Refuel. This is new, it's effective. Some of you are going to be able to work with these concepts readily. Others, you're gonna wanna put it on your radar screen and put it on your long-term kind of growth path. But this is, it is a culture change and it is part of the path toward high value care. Next slide. So in summary, here are your phase 3 refueling stops. Number 1 is view the emergency room as an opportunity to reduce readmissions. Number 2, work to increase treat and return for patients who come to you from SNFs through the tools and the processes that we described. Number 3, facilitate that reach in, transition out pathway when a patient of yours has already been connected to a transitional care team or a community-based care navigator or a primary care with care management. Reach in, transition them back out. And finally, use ED care alerts to help inform the decision to admit, especially when the human beings can't be there to reach in and transition out. Next slide. So I'm seeing the time, we have like 1 or 2 minutes, so I'm gonna quickly scan through the chat here before I turn it back over to Kate. And I want to just see if I can quickly address some of these questions. So question from Vicky was, with the care alert, do you have people on call for the PCP and care team? So so this could be a couple of things, Vicky, and there's, in this case, the care team, the most straightforward answer is, don't put anything in a care alert that you're not willing to do, right? So you could have had that care alert for Mr. F without the line from the PCP saying, call me if you're contemplating testing, right? It happened to be that she was good and sick of her patient being admitted 15 times a year every time he hit the emergency room. So she wanted that. And that was her decision, and she wanted that, and she put that in. But you know, we could do I teach day-long seminars on this stuff, and there are other ED care alerts that say, please be aware the patient is enrolled in St. Mary's Hospital Transitional Care Program. Her care manager is Amy Boutwell at ... phone number, available Monday through Friday, 9 to 5. I mean, if that's the reality, that's the reality. But at least now the ED doc in the future knows that the patient is enrolled in the St. Mary's Hospital Transitional Care Program. And so you create the information, you push the information that you are comfortable with and that's, represents the reality. So great question. So we're going to post the Interact tools. Great. And somebody asked me about LACE. And I agree, Cheryl, somebody mentioned Boost. So you might go back to our first webinar where we talked about data and using your data. Honestly, I don't know, Cheryl, if you're a very small critical access hospital, but if you are a small critical access hospital, there's probably no point in stratifying your patients using LACE or really any risk stratification. The point of risk stratification is only when we can't serve all of our patients. But if we only have 5 readmissions, I'm just using that as an example. If we only have 5 readmissions per month and you have, we'll say, 100 discharges a month, which is 3 discharges a day, you can improve the discharge for all of those 100 patients per month. You might not enroll all of them in transitional care by any means, but we can make appointments and follow-up phone calls and have pharmacist-based med rec or RT-based teaching across the board. And that's probably what critical access hospitals might want to think about is, do we stratify or do we not stratify? So that's kind of concept number one. Quick concept number two is about LACE. Make sure you know what LACE is and make sure you agree with it. L is length of stay. The way L is calculated in the EMR is based on the national average length of stay for that DRG, which makes no sense clinically. Number two is acuity. That simply means was the patient admitted through the emergency room? Well, most of our patients are admitted through the emergency room, so it's nonsensical. It doesn't have any value to us. C is the only part of LACE that has any potential value. It's based on the Charleston Comorbidity Index. Now that's actually doesn't even include things like poverty or behavioral health comorbidities. So I'm okay with C, but C is not even that good. And then E is the number of ED visits in the past 6 months. Again, not bad, but not better than some of your own data analysis that we discussed in webinar 1. So, if you're using LACE, just make sure you believe in LACE and the sum total of that score as a way of differentiating, is Mrs. Smith at higher risk of readmission than Mr. Jones? And don't use LACE if you don't believe it. But if you do use LACE, then at least you'll know why, and at least you'll have confidence in who you're looking for and why you've made that decision. So great question. Okay, well with that, I think I will turn it over to Kate to wrap us up with next steps and close us out.
Thanks so much, Dr. Boutwell. I am just so excited to see what you guys are all going to get accomplished in phase 3 of work. We, I think, collectively have this really great opportunity to engage the ED in our readmission reduction strategy. So I hope you'll use this new knowledge to help refuel you as you dive into phase 3 of work. A couple just very brief reminders for next steps. Share and implement, share and implement, share and implement. Make sure that you're sharing with your care team the whys of why we should do this work, so that when we move to implementation and we ask them to do things differently, they understand and they're as connected to the why as we are. Request coaching if needed. Please do reach out to me via email or my phone number. And if you'd like facility level coaching during phase 3, please reach out to me and we'll get that scheduled in the coming weeks. And then one last reminder that we'd like you to go ahead and get registered for our final webinar. As we wrap up the project, it's scheduled for June 27th. And so we will be having some of the hospitals from our cohort presenting on some of their REFUEL project work, and also be discussing some next steps as this project concludes. With that, we are past time. I want to thank you all for joining us today and have a great afternoon.